allow me to. Okay. So I think we can start. Let's start by hearing a little bit about yourself. I see there's a slide already that tells us about you. Please, we can start from there and then you lead us on into the presentation.
Okay, so I can start.
Yes, please, you can start.
All right, good evening, everybody. My name's Richard Silavwe. I'm from Zambia. I'm a sonographer, but I started my profession as a radiograph technologist at Ron General Hospital in Zambia, Luansha in particular. Thereafter, I went to do my bachelor's in medical imaging in Uganda, Kampala. Thereafter, I came back and I worked at Arthur Davison Children's Hospital for quite a number of years. Then later on, I went and I studied my master's in medical ultrasound. Then after my completion, then I went and joined a private hospital in Namibia, where I'm currently based. This evening, I'll be presenting on a subject that I've entitled bile ducts. So we'll be talking about the bile ducts, as you can see from the screen there. So the bile ducts, the initial imaging of the bile duct, most of the time we have indications of the right upper quadrant pain, then also jaundice. Then we have diseases of the bile duct, which are usually manifested like obstruction of the bile duct with resultant dilatation of either the intrahepatic or the extrahepatic duct, or there can be both dilatation. Extrahepatic duct, we are going to look at the anatomy. Then we also look at the common diseases that affect the duct. We have Choledocholithiasis, we have Mirizzi syndrome, we have common bile duct sludge. We have also Ascariasis. We have cholangiocarcinoma. We have rhabdomyosarcoma. Then we also have periampullary carcinoma. Then intrahepatic bile duct, we continue. We have also the intrahepatic dilatation, then also cholangitis. We have Pneumobilia, intrahepatic biliary calculi, Choledochal cysts, then Biloma. Then on extrahepatic biliary duct, I just showed the anatomy there on the schematic diagram there. You can see we have the right hepatic duct there, the left hepatic duct, the common hepatic duct, which form the intrahepatic. Then we also have the gallbladder there. We have the cystic duct. We have the common bile duct. We have the pancreatic duct there, and also the ampulla ovata. Extrahepatic duct, the normal anatomy, the right and the left hepatic duct join to form the common hepatic duct, which is the actually anterior to the right and the main portal vein. Okay, just a moment, please. Okay. So I was talking about the anatomy, the normal anatomy. The right and left hepatic duct are joined to form the common hepatic duct, which is located anterior to the right and main portal veins. Approximately 3 centimeters from the confluence of the right and left hepatic duct. The distal cystic duct joins the common hepatic duct to form the common bile duct. In the portal hepatis, the common hepatic and the common bile duct are located anteriorly to the main portal vein. Then the main proper hepatic artery is also located anterior to the portal vein, but it is usually medial to the common bile duct from the portal hepatis. The common bile duct, along with the main portal vein and the main proper hepatic artery, descends within the hepatoduodenal ligament. The distal common bile duct passes behind the duodenum and then runs in a groove on the upper and lateral part of the posterior surface of the head of the pancreas, anterior to the inferior vena cava. The common bile duct and the pancreatic duct usually join together to form the ampulla ovata in the descending part of the duodenum. Then the common hepatic duct is approximately 3 centimeters long, and the common bile duct is about 7.5 centimeters long. Showing you the image there. You can see the gallbladder there. We have the cystic duct, and we have the portal vein. This is another image just showing the structures, as you can see there. Then we also have another view there showing the common bile duct somewhere here. These are just images. Then we are going to look at the causes of biliary obstruction. Some of the causes of biliary obstruction are choledocholithiasis. We are talking about the calculi. Then we also have neoplasm. These are cancers. We have also inflammatory disorders of the biliary duct. The biliary duct tree can also be affected by some infection, which can cause it inflamed and later on cause obstruction to the biliary tree. Then the common bile duct is most easily identified. It is mostly identified through its association with the portal vein, and the portal vein is most easily identified in the long axis of the gallbladder. It is the point of exclamation mark, like in English, that exclamation mark, where you see the common bile duct looking like a point. So it is the point of exclamation point that is created with the gallbladder in the long axis. When you follow the main lobar fissure from the neck of the gallbladder to the portal hepatis, the portal vein will appear as a large hypoechoic circle with echogenic holes. The common bile duct and hepatic artery will appear as two smaller circles anterior to the portal vein. Oftentimes, it gives the appearance of a face with two ears, also called Mickey Mouse. That is just an image there. Then in transverse, you see the milk mouth, whereby you see the photohepatic showing the relation of the main hepatic artery and the common bile duct. I have the image here, which is showing the hepatic artery here. Then we have the portal vein here. Then we have the common bile duct here. That is the milk mouth, which shows something like the two eyes and the head, or 2 ears and the head. That's a milk mouth sign. Then, because sonographically the junction of the distal cystic duct and the common hepatic duct cannot be seen in everyone, that's why we have the term called common duct. We usually use this word common duct because of this reason, whereby sonographically you are not able to see the cystic duct and the common hepatic duct. You are not able to see it in everyone, but some of the people, you can easily see those ones. The common duct can be divided into the proximal and the distal segment. The proximal or higher up portal-hepatic segment is anterior to the main portal vein. Then the distal segment can, the proximal higher segment is anterior to the main portal vein, but the distal segment can be further divided into suprapancreatic and pancreatic portions. So the suprapancreatic portion is between the portal hepatis and the pancreatic head. That is the head of the pancreas. And the pancreatic portion is at the level of the head of the pancreas. So this one, I'm just showing you the common duct, the proximal common duct, the distal one, which has got the suprapancreatic duct and the pancreatic duct. Sonographically, on the longitudinal view, the proximal segment is seen anterior to the right and main portal veins and runs parallel to the main portal vein. Most of the distal segment runs almost parallel to the plane of the inferior vena cava in the sagittal axis. Most patients have a dorsal bend or angle between the proximal and distal segment. This angle is designated the gain of the common duct. I'm going to show you in the next slide what we are talking about. At the level of the pancreatic head, the common duct is seen posterior to the head on the longitudinal view and posterolateral to the head on the transverse view. So the one we are talking about is this junction here, which looks like a bend, where we have the distal common bile duct here, then we have the proximal common bile duct here. Here we have the hepatic artery, and here we have the portal vein, just posterior to the common bile duct. These are some of the views which are showing the normal distal common duct, pancreatic portion. You can see the part of the pancreas there. You can see the hepatic artery. You can see the IVC there. In transverse view, you can see what we have here. We have the gallbladder. We have the common duct here. I guess I don't know if my case you can see it properly. Okay, we have the aorta there.
Yes, we can see it.
Okay, thank you. Then the right hepatic artery appears as a rounded and echoic structure. The right hepatic artery forms an indentation frequently prominent on the wall of the common duct. between the common duct and the portal vein in approximately 85% of patients, and is seen anterior to the common duct in approximately 15%. This is also a schematic diagram which is showing the intrahepatic and also extrahepatic duct. These are just views. You can see here, we have the portal vein here. Anterior to it, we are able to see the common bile duct there. Then you are able also to see the hepatic artery. All these are just images, just showing us the relationship of the portal vein to the common bile duct. The size of the common bile duct in normal duct has been reported to be as small as 4 millimeters or as long as 8 millimeters, though other literatures, they say up to 7 millimeters, and they say the common bile duct, it increases after every decade. After 50 years, you find that the patient, you will be able to discover that the common bile duct enlarges by a simple centimeter. So you should not be surprised to find, for example, in a 70-year patient with a common bile duct measuring 9 centimeters. You should consider it that it could be a normal thing in such ages. So we are saying that these discrepancies are primarily due to location of the common duct measurement and also possibly related to respiratory phases. Then the distal portions of the common bile duct are usually larger than the proximal portion. A few patients may have an increase in ductal diameter of 1 millimeter or more after deep inspiration compared with the diameter measured in expiration. So these are just images that I'm showing you here. We are still looking at the duct and the portal vein. Then we are still looking at the IVC here. You can see the duct here. So these are the parts of, for example, this one is a distal suprapancreatic common duct, which is here, just anterior to the IVC. We are able to see that one there. Then the cystic duct, normal distal cystic duct can be seen in 51% of healthy patients and has an average mean diameter of 1.8 millimeters. The distal cystic duct is seen much more frequently when it is dilated. Then they are saying, according to literature, in 95% of patients, the distal cystic duct is located posterior to common duct or the common bile duct. And in 5%, it is anterior to the common bile duct. So we can see from here, I have some images here where we are able to see the cystic duct. Okay, we are able to see the portal vein. Here, the cystic duct is entering the common duct posteriorly. Then we have the common hepatic duct. It's here, anterior to the cystic duct. And we also have the portal vein here. So these are just images. Then we have another image here, which is showing us the hepatic artery. Also, it is showing us the portal vein here. We have the portal vein here. Then we also have the common bile duct. So these are just images that we are scrolling. Then the scanning technique, the proximal common duct is examined by sagittal scans with the patient in supine as well as the left posterior oblique position. The scanning is started in the sagittal plane in the mid-clavicular line subcostally and is continued using slight changes in position of the transducer and varying angulation of the sound beam until the main portal vein and the common duct are identified. So basically here, you'll be able to scan the patient in supine position. Sometimes you can scan the patient in the left posterior oblique. Then you'll be able to angling the transducer to make sure that you identify the portal vein. The moment you identify the portal vein and you elongate it, you'll be able to see the common bile duct just anterior to the portal vein. Then you are able to measure it and see if it is dilated or not. And most of the time, subjectively, even before measuring, you can tell that it is dilated or it is not dilated. So the distal common bile duct can also be demonstrated using this technique. However, it is located more medially and is better seen with the patient in the supine position rather than in the left posterior oblique position. So the distal common bile duct, especially the pancreatic portion of the duct, is frequently better seen by transverse scans with the patient in an erect right posterior oblique position. If the distal common duct is obscured by the shadowing from the bile gas, patient can be examined in an erect position after they have ingested water. So basically, if you see that there is too much shadowing coming from the bowels, especially the gases, you find that the gases will be shadowing and you are unable to see the duct properly. So you advise the patient, or you can tell the patient to take water. When they ingest water, then you reduce the gases that are able to obscure the visualization of the common bile duct. So the distal cystic duct is best seen by sagittal or sagittal oblique scanning with the patient in supine or the left posterior oblique position. It may also be demonstrated by transverse scanning. So you can use either of the position for you to check the cystic duct. Most of the time, it's very difficult to visualize it, but in most of the patients, if you can maneuver with the probe in terms of positioning and also angulation of the probe, you are able to capture the cystic duct. So we'll be talking about the some of the diseases that affect the duct. We have Choledocholithiasis, which I already mentioned that you'll be able to find the stones in the duct. They are very common in some individuals, like here in Namibia. It's very common to find the renal stones, gallbladder stones, and also the duct stones. I really don't know why it is like that. Maybe it's the weather here is very hot. Maybe people don't take a lot of water, you know, such kind of a thing. So it's very common to see actually these stones or calculi in most of the patients that we scan here. Then I'm just showing you the stone here. That's a common bile duct. That's a stone there. We have another stone here. We have another stone here. So most of the time, the stones will show acoustic shadowing. That's the black thing that goes posterior to the stone. But some of the stones may not show the acoustic shadowing. This is another image in transverse view where I'm showing you a stone. There is a stone here. You can see here, there is a stone. This is the portal vein. And then we have the portal confluence here and the hepatic artery somewhere here. These are just images that I'm showing you. You can see some stones, multiple stones in the common bile duct here, and the acoustic shadowing the black thing that is going down there. You can see also here, there are multiple stones here. They are also casting the dark shadow posterior to the stones. All these are just images. We can see some mobile duct stones here. You can see these small ones here, but they have some shadows there. You can see these ones. Okay, these are also images, gallstones and choledocholithiasis with dilated common bile duct and intrahepatic duct. You can see the stones all over here. The ducts are dilated. Most of the time when you want to differentiate if what you are seeing are stones, meaning duct, or maybe they are just other vessels, you just put color there. You find that if you are talking about the intrahepatic duct dilatation, you will not be able to see color flow there on the dilated duct. You just see anechoic tubular lines there. So these are just some of the images. You can see the stones there in the bile duct. All these, we are showing the common bile duct, which is dilated due to the stones. Here we have this stone here. So all these are just images showing us what is going on in the duct. Then we have what we call a barrel sign. You can see this one looking like a gun, the two pipes of the gun. So we have the common bile duct here when it is dilated and the portal vein. So they will be seen like the double barrel. So we call it a double barrel sign, which simply tells you that there is an obstruction somewhere in the common bile duct, especially on the distal part of the common bile duct. Then we have the distal cystic duct stones, which is called Mirizzi syndrome. So Mirizzi syndrome, it's basically the stones that obstruct or are impacted on the cystic duct. So you can see this schematic diagram here. This is the gallbladder, and the whole of this, that's the neck of the gallbladder. And then we have here the cystic duct, and there is a stone impacted here. Okay. So this is Mirizzi syndrome. This is just a picture that I'm showing you here, where you are able to see the stones, and you are able to see the cystic duct, which is impacted with the stone here. The stone is here. Mirizzi syndrome is a rare but surgically correctable cause of extrahepatic biliary obstruction. It is caused by impacted cystic duct, like I mentioned earlier on. So the stone leading to extrinsic compression or inflammatory stricture of the common duct, resulting in obstructive jaundice. So you find that there will be obstructive jaundice when the cystic duct is obstructed, but it is something they are saying here that it can be corrected by surgery. So surgically, the surgeons are able to remove the stones. Like at our hospital, we have a special investigation where they don't necessarily operate like maybe cutting the cystic duct, but they just insert something like endoscope. Then they are able to remove, to extract the stones from the gallbladder, even the cystic duct. So that examination is done at our hospital. Then sonographic features: a gallstone impacted in the distal cystic duct or the gallbladder neck, there will be dilatation of the biliary system, including the common hepatic duct, and an abrupt change of the dilated common hepatic duct to normal diameter below the level of the cystic stone. So you can find sometimes the common bile duct has a normal diameter, and yet there is an obstruction somewhere. So a low cystic duct insertion associated with a parallel course shared by long distal cystic duct and adjacent common hepatic duct. So Mirizzi syndrome cannot be detected routinely on sonography, and when suspected, computed tomography and cholangiography should be performed. So they are saying most of the time we may not be able to see the impacted stone in the cystic duct. So if we are suspecting that there could be an obstruction at the cystic duct, we should be able to write in our report on the recommendation. You just recommend CT scan, and then the stone will be detected by computed topography, which is the CT scan. Then we can see here, I'm just showing you the impacted stone. Sorry. Is there a question? Okay, we can continue. Okay.
Continue, sir.
Okay, thank you. So the impacted stone in the neck of the gallbladder, that's what I'm showing you here. We have the stone here. Then the stone is here. Okay, so we see that the common bile duct is dilated. These are just pictures showing us the cystic duct impacted by a stone. Then we also have the common bile duct sludge, just the way we find the sludge in the gallbladder. We can also find sludge in the common bile duct. So it is uncommon finding, but you can occasionally find it by demonstrating layering within the common bile duct. So you find that in the common bile duct, you find like something like fluid levels. So you'll be able to see echogenic regions layering down there. Then the bile will be on top of the stones, of the sludge. So biliary sludge leading to biliary obstruction can ascend cholangitis. It is a life-threatening and complication of liver transplantation, and is seen in 10% to 29% of these patients. So these are just pictures or sonograms that I'm showing you. That is sludge in the common bile duct. We can see here. So this is a longitudinal view. We can see the layering. We can see bile there. Then here there is sludge there. So this is also sludge within the common bile duct. The arrows here. So that is sludge there. Then we also have a biliary parasite, like we mentioned earlier on. So we have Ascariasis. Ascariasis is caused by the roundworm Ascaris rhombocoides. So we are saying the worms can also be found in the biliary tree. I've not seen any of the worms like here in Namibia, but when I was in Bangladesh, I was able to do a lot of sonars whereby you find the Ascariasis in the common bowel duct. They are very common in Asia. You find that most of the patients that we are coming for sonograph, we could be able to detect the worms. We'll be able to see them physically, even sometimes moving right there in the common bowel duct. But here in Namibia, I've not found any. Even in Zambia, I never saw a patient with the worms in the common bowel duct, but they are actually there. Sonographically, adult worms or roundworms can be seen in the common bowel duct as non-shadowing tubular echogenic structures containing a central anechoic line or as a non-shadowing echogenic strip. So if you see you are scanning a patient and you check the common bowel duct and you are able to see this, what we are describing now, like a tubular thing, which is echogenic, containing a central anechoic line, then you know you are dealing with the Ascariasis. Then multiple worms, you can see echogenic strips giving a spaghetti-like appearance. We all know spaghetti, we eat spaghetti. So you'll be able to see spaghetti-like appearance when we have multiple worms in the common bowel duct. So the gallbladder, Ascariasis can actually lead to acute cholecystitis, then in intrahepatic biliary tree causing cholangitis and the liver abscess. So these are some of the causes of hepatic or liver abscesses. You'll be able to see abscess. You can suspect that there could be Ascariasis somewhere in the duct, though it is not always that an abscess can be caused by the presence of the worms. In the gallbladder, echogenic strips as echogenic cause or less commonly as echogenic amorphous fragment or without acoustic shadowing. These are just descriptions that we are talking about concerning Ascariasis. So this one here is a sonogram showing Ascariasis or the roundworm. You can see here. Okay, this is the portal vein. Anterior to the portal vein, we have the common bowel duct. Then we can see there is a worm here. So that's a worm there. Here again, we can see the worm here. Okay. We can see another round worm here. The arrows here, then fetching there. Okay. Then we are going to talk about cholangiocarcinoma. So we talk about cholangiocarcinoma. So it is a slow-growing malignance of the bowel duct epithelium, second most common primary hepatic malignant tumor. So let me just quickly go forward. I know that time is not so much with us. So we can have carcinomas of the biliary tree, or especially the duct, where we are able to see the carcinomas or the cancer in the duct. Then we have the type where we find it on the higher region. It is called Klatskin tumor, cholangiocarcinoma. That's the other type. So hilar cholangiocarcinoma most often occurs at the confluence of the right and left hepatic duct and the proximal common hepatic duct, and it is usually cirrhosis type. Tumors at this location, at the bifurcation of the common hepatic duct, are referred to as cracking tumors. So these are just statistics where they are telling us about the statistics of this type of tumors. Then sonographic findings in higher tumors, you find dilatation of the intrahepatic bile duct, but not the extrahepatic duct. So most of the time when you look at the extrahepatic duct and you are unable to see dilatation, but you can see the dilatation in the intrahepatic, you will be suspecting of this type of tumor. Okay. Then hepatic lobar or segmental atrophy can occur after obstruction of the ipsilateral portal vein by higher cholangiocarcinoma. So the tumor can infiltrate the wall of the portal vein, causing portal vein thrombosis, which is much less common than hepatocellular carcinoma. Hepatic invasion or lymphadenopathy may occur. So these are images just showing us this type of tumor with a mass in the liver at the hilum level. You can see this is the hilum area here of the liver. Okay, so this one is now obstructing the bile duct, hence causing the dilatation of the intrahepatic duct. Then we have the distal types, cholangiocarcinoma. This cholangiocarcinoma of the distal common hepatic or common bile duct are usually small and have a better prognosis than the higher. So they are saying the issue of treatment here, when you are treating the one that are found on the higher area of the liver, the one that caused the intrahepatic obstruction quite difficult to treat than the one that are found on the extrahepatic. So the prognosis is very good for the extrahepatic biliary. So we can see here, I'm just showing you the cholangiocarcinoma here. Okay, this is the portal vein. This is the common bile duct. Then we have this mass here. It appears echogenic. So this is the longitudinal view demonstrating echogenic solid mass here. That's the one, that's the mass there. Then some pitfalls when you are imaging the duct. Sludge within the common duct can appear echogenic and may mimic intraductal soft tissue mass. So we need to be conscious when we are doing the sonography or we are scanning the patient. Sludge may mimic like something that is a soft tissue mass, and yet it is not a mass, but it is just a sludge. So clinical presentation and change in appearance or resolution of the sludge on follow-up examination are helpful in the differentiation. Okay. So other malignant neoplasm, we have the rhabdomyosarcoma. These ones sonographically, they are solid masses containing hypoechoic areas secondary to rhabdomyosarcoma of the bile duct within the liver, as well as in the portal hepatis involving the cystic duct, which have been described already. So these are just images showing us the masses that we are describing. Then we also have periampullary carcinoma. So these are carcinomas, a group of neoplasm arising from the bile duct, pancreas, or duodenum. So these are other carcinomas that you may find in the duct. So this one here, we are able to see the dilated common bile duct. Okay, that's a common bile duct. Then we are able to see a mass here. There is a mass here which is obstructing the duct. This one also is showing us the head of the pancreas mass here. There is a mass here. Then we have the pancreatic head mass also here. You can see the arrow. Okay. Then we will talk about intrahepatic bile duct, which we already mentioned in terms of anatomy and the other thing. But now here we will talk about the dilatation, the cholangitis, Pneumobilia, intrahepatic biliary calculi, cholangiocarcinoma cyst, and Biloma. We'll just go quickly. So the normal anatomy here, intrahepatic ducts run parallel. Sorry, okay. Okay, parallel to the portal veins and the hepatic arteries. We are just repeating what we already mentioned. So the relation of the intrahepatic bile duct to the portal vein is variable. Like we mentioned, sometimes you can find it anteriorly, sometimes posteriorly. So because of their small size, normal intrahepatic bile duct are difficult to demonstrate reliably by ultrasound examination. Because most of these ducts, the measurement is less than 2 millimeters. So it's very difficult actually to see them on ultrasound if they are not dilated. These images showing the duct. Okay, we have intrahepatic biliary dilation. In the past, the parallel channel sign was considered as something that was significant to say the duct are dilated. But now they are saying the parallel tubular structures cannot be considered diagnostic of biliary dilatation unless the tubular structures adjacent to the portal veins are larger than 2 millimeters. So we are saying when we are doing the sonography, you are scanning the patient and you see the duct parallel to the portal vein, we cannot just conclude and say this is dilatation unless if the diameter is greater than 2 millimeters. So that is when we can say there is intrahepatic biliary dilatation, only when it is more than 2 millimeters. So parallel channel sign of biliary obstruction secondary to cholangiocarcinoma. So this one here, we can see the portal vein, then we are able to see the biliary duct dilatation there. It is dilated there. Sonographic criteria for diagnosis of biliary dilatation and for differentiation between bile duct and portal veins include: number one, alteration of the normal anatomic pattern of the portal triad, irregularity of the walls of the bile duct secondary to tortuosity, then sterate confluence of the dilated tubular duct, then acoustic enhancement behind the dilated bile duct. So acoustic enhancement is frequently seen behind the dilated duct and usually not seen behind the portal veins. So we can see these images that are showing us the dilated duct there, and we can see the enhancement behind there. So all these are just images showing us the dilatation of the intrahepatic duct. Okay, this one here is just a schematic picture, but the real sonogram are there, just showing us the dilated biliary duct. Here, there is a simple illustration here, whereby if you want to look at the obstruction, there are two things here, obstruction and non-obstruction. So you will find that when there is a stricture or stones, there are things that you can look at or you can suspect to have caused the dilatation. Okay, there are times when they are dilated without obstruction, and there are times when they are dilated without obstruction. So when there is obstruction, you suspect neoplasm. These are cholangiocarcinoma, gallbladder adenocarcinoma, pancreatic adenocarcinoma, metastasis, or post-inflammatory pancreatitis, post-radiation or chemotherapy. Then inflammatory, you can find AIDS cholangiopathy, biliary parasite, primary sclerosing cholangitis. Then on the non-obstruction, you find that the dilated part, there is no obstruction. So these are the conditions below here, which can cause dilatation without obstruction. That is Caroli disease, Choledochal cyst, recurrent pyogenic cholangitis, primary sclerosing cholangitis. I'll talk about this in the next slide. So dilated hepatic arteries in the liver are seen most often in patients with cirrhosis, and portal hypertension may mimic dilatation bile duct. These structures, however, can be easily distinguished by a color Doppler. So if you want to differentiate, to know if these are intrahepatic dilatation of the duct or they are just vessels, you just apply color Doppler, like I mentioned earlier on. So when you put color Doppler and you are able to pick color there, then we know that it's not intrahepatic dilatation, but we are dealing with the just the blood vessels. But if you apply color Doppler and you are unable to pick color, then you know that you are dealing with intrahepatic dilatation. But I must emphasize one point here. You should be very conversant with the use of color Doppler in terms of settings, because sometimes, for example, if you have not set the frames properly, you'll find that you may not be able to see color, and then you may conclude that it is intrahepatic dilatation when it is in the actual sense not. Why? Because you have not done the settings properly. So you have to make sure the filter is okay, the PRF is okay, then you'll be able to put color. If they are vessels, then you'll be able to pick color. If they are not vessels, then you will not be able to pick color. Cholangitis. We have bacterial cholangitis, ascending cholangitis, primary sclerosing cholangitis, oriental cholangitis, recurrent pyogenic cholangitis. So these ones are things that are caused by bacteria. So bacterial cholangitis is almost always associated with biliary obstruction, causing bacterial infection secondary to bowel stasis. So benign causes of obstruction are much more likely to cause bacterial cholangitis than malignant causes. So cholangitis can also occur in up to 18% of patients with biliary enteric anastomosis. So patients present with, clinically with right upper quadrant abdominal pain, chills, fever, and jaundice. Then sonographically, significant ductal dilatation and identifies the cause and level of obstruction. So sonography is able to help us to actually diagnose or make a diagnosis of bacterial cholangitis. Then we also have in acute ascending cholangitis, prurulent bowel may be identified as intraruminal echogenic material within the dilated bowel duct. Then the hepatic abscesses not uncommonly complicate bacterial cholangitis. Then prompt biliary drainage is mandatory, and the sonograph may be variable in guiding percutaneous biliary drainage. So sonographically, you can help actually the radiologist or the doctors to be able to drain, like for example, the abscesses. That is what we are talking about here by a variable in guiding percutaneous biliary drainage. So chronic obstructive cholangitis with repeated infections may cause ductal strictures, intrahepatic or extrahepatic ductal wall thickening, peripheral narrowing of intrahepatic bile duct, and the biliary cirrhosis. So I'm just showing you a sonogram here where the walls of the duct are thickened. The duct is here, it is dilated, and also we have thick walls. Then primary sclerosing cholangitis, a chronic cholestatic disease of unknown origin that is characterized by diffuse fibrosing inflammation of the intrahepatic and extrahepatic bile duct, resulting in biliary cirrhosis and hepatic failure. So the term primary is used to distinguish this disease from the biliary restriction that may result from operative injury or choledocholithiasis. It is associated in nearly 75% of cases with ulcerative colitis and approximately 70% of patients in male younger than 45 years of age. Clinical features include fatigue, pruritus, right upper quadrant pain, jaundice, and hepatosplenomegaly. Cholangiography include multiple short segmental strictures, beading, pruning, diverticular. I will show you the images at the next slide of what I'm talking about, and the neural thickening of the duct. So when you look at this image here, you are able to see what we are talking about. You will find that there is irregular wall thickening of a dilated right intrahepatic bile duct. The arrows here. Can we see the white arrows there?
Yes, we can see them.
Yes. Okay, so that one is telling us about the right intrahepatic duct. Then the echogenic septations within the bile duct are secondary to several annular strictures within the duct. Okay, then you can see these ones also here. It's the same thing, sclerosing cholangitis. Okay, that's a duct, but we have these echogenic things here, the arrows, the very small arrows here. The portal vein is just posterior to the common bile duct. Then we have recurrent pyogenic cholangitis. Recurrent pyogenic cholangitis, commonly known as oriental cholangitis, is endemic in Southeast Asia and is characterized by recurrent attacks of abdominal pain, fever, and jaundice. The cause of this disease is unknown, but parasitic infestation, malnutrition, portobacteremia, and intrahepatic calculi secondary to congenital biliary strictures have been etiologically implicated. So pathologically, the intrahepatic and extrahepatic duct are directed and contain soft pigmented stones and pus. The pathological changes are most marked in the intrahepatic duct with patchy stenosis and dilatation of the bile duct, secondary to fibrosis. Secondary biliary cirrhosis may develop after repeated infection. So all these we are just talking about the recurrent pyogenic cholangitis. So sonographic findings include intrahepatic or extrahepatic duct stones, dilatation of the common bile duct, and right and left hepatic duct with relatively mild or no dilatation of the peripheral intrahepatic duct. Localized dilatation of the lobar or segmental bile duct, especially left lobe bile duct, wall thickening, increased periportal echogenicity, segmental hepatic atrophy, and gallstone. Then the gallbladder is distended and palpable in about 30% of cases. So it's not all the cases where you can palpate the gallbladder in a case of recurrent pyogenic cholangitis. But in 30%, it has been documented that you can actually palpate the gallbladder. So the stones are usually of medium echogenicity with variable degree of acoustic shadowing, and they may be difficult to demonstrate in the absence of acoustic shadowing. So it's a bit difficult to actually demonstrate the absence of acoustic shadowing. So this is what we are talking about. You can see the shadowing here. We can see that the small arrows there. Okay, the small arrows. So that's a transverse view in another patient showing multiple intrahepatic biliary calculi. Okay, those are the ones that we are talking about. Intrahepatic biliary calculi. Intrahepatic biliary calculi, you can also find the stones in the duct within the intrahepatic biliary system. So this one here, it's just showing us the stones. You can see the acoustic shadowing, the dead shadow that is coming down there posterior to the stones. Okay, intrahepatic biliary calculi are uncommon in patients with gallstones, but they frequently occur in patients with recurrent pyogenic cholangitis, benign or malignant biliary strictures, Caroli's disease, or other causes of intrahepatic biliary stasis. Sonographically, biliary calculi are seen as focal hyperechoic structures, usually with clean distal shadowing, and are located adjacent to the portal vein branches. Associated bile duct dilatation is frequently seen. So that's a sonogram there. We can see the arrow pointing to the stone, and the stone is casting a shadow here. Okay, can go to the next slide. Calcified arteries, intrahepatic arterial wall calcification also occur adjacent to the portovenous branches, and when associated with the acoustic shadowing, they may mimic intrahepatic biliary calculi. Computed tomography in this patient is helpful by demonstrating arterial calcification. So here again, if you find that there are calcifications in the arterial system, you should be able to recommend the CT scan so that we can differentiate if we are dealing with the intrahepatic duct or we are dealing with the arterial calcification. So these are the calcification. We have calcification, transverse view of the liver, air in the bile duct. Here we are dealing with the calcification, the stones there. Okay. You can see the green shadow, acoustic shadowing. You can see other hyperechoic foci arrows here. You can see these ones here. These arrows here, they are pointing to this. And the shadows are moving like that. Okay. So that is the calcification. So the Pneumobilia is just mimicking the calcification. Pneumobilia, air in the intrahepatic bile duct. Air in the bile duct frequently obscures the lumen of the dilated bile duct. So Pneumobilia can be caused by surgery, okay? Biliary enteric anastomosis, biliary enteric fistula complicating biliary surgery. So incompetent sphincter of OD, erosion of gallstones into the gastrointestinal tract, peptic ulcer erosion into the common bile duct, and acute emphysematous cholecystitis with a patent cystic duct, and cholangitis due to gas forming organism. With the patient in the supine position, the gas preferentially fills the anteriorly located left hepatic bile duct. So you'll be able to see the gases in the duct. Pneumobilia, sonographically, pneumobilia is characterized by echogenic foci, either short or linear in the distribution of the bile duct. The echogenic foci may cast an acoustic shadow and frequently produce reverberations and comet tail artifact. We know this artifact. A small amount of air in the bile duct may produce clean shadow without reverberation and may mimic biliary calculi or liver calcification. So this is what we are talking about. Air within the intrahepatic bile duct. You can see here the arrows here showing us the green shadow there. You can see all these that is in the river. We are able to see air in the intrahepatic bile duct appearing as multiple linear or band-like hyperechoic areas. So some associated with distal acoustic shadowing, like this one, which is labeled S, then a comet tail sign or ring down artifact. Yeah, the long arrows there, they are showing that one there in the bile duct appears as hyperechoic focus, like in figure A here on the sonogram A here. You can see that one. So other hyperechoic foci arrows secondary to air in the bile duct are seen with less obvious acoustic shadowing. Choledochal cyst, we talked about choledochal cyst. You can find cysts actually in the duct. The duct can look like they are bulging. Then you are able to see that one. So this one is an uncommon anomaly of the biliary system manifested by cystic dilatation of the extrahepatic or intrahepatic biliary tree or both. Choledochal cysts most commonly involve the common bile duct. There is the ratio of 3 to 1 female predominance, and 60% of cases are present before 10 years, although choledochal cysts can also present from birth to old age. The clinical picture varies from absence of symptoms to the classic clinical triad of pain, jaundice, and abdominal muscle. So these are just clinical symptoms. Now, these are classified into 5 types. We'll quickly look at the diagram. The first diagram here is talking about the cystic dilatation of the common bile duct. This one, that's a common bile duct, it is dilated. Then the second image is talking about the focal segmental dilatation of the common duct. You can see here, instead of the whole of it to be dilated, only a segment of it is dilated. And then we have image number 3 here, okay, which I've indicated IC. It's a fusiform dilatation of common duct. Then we have this one here, the 4th image here. You see this one here? Yes, that is through the verticulum arising from the common bile duct. So this part here is the common bile duct. Then we have this cyst here. Then we have the 5th image here, that is Choledocholithiasis. Then we have another one here, 5A, the 60th image here. Yes, this one here is multiple intrahepatic cysts. Multiple intrahepatic cysts. We can see the cyst here. Okay, you can see here the right hepatic duct here and the left hepatic duct, there are cysts here. Then we have the other image here, that is Caroli's disease. It's talking about Caroli's disease here, intrahepatic cyst. That means those cysts are within the liver. Type 1, sonographically, the anechoic cyst mass in continuity with the common bile duct. We will not dwell much on this one because we are just from describing them now. The one that we described, these are the ones that we are talking about. These are images showing type 1. The other image showing type 1b. The other one, the images that we are describing were schematic, but these are real sonogram. This one is talking about type 2 and type 3. So Caroli's disease is a rare congenital malformation causing non-obstructive multifocal circular dilatation of intrahepatic segmental bile duct, frequently associated with the infantile autosomal recessive polycystic kidney disease and congenital hepatic fibrosis. These are normally present at birth and remains asymptomatic for the first 5 to 20 years. So you find that a child can be born with the Caroli's disease, but then the child will grow up maybe up to 20 years without maybe being diagnosed with that. And then maybe when that patient comes to our department, then you'll be able to discover that actually there is Caroli's disease in the patient. So most common complications are recurrent bacterial cholangitis, cholangiocarcinoma, and hepatocellular carcinoma. Sonographically, you'll find cysts of varying size. They are seen scattered throughout the liver or are confined to part of the liver. Then you'll be able to see tubular or circular dilatation of the segmental bile duct, which may be associated with the cyst. Okay, I will not talk much about that. So computed tomograph may demonstrate tiny dots within dilated bile duct that enhance after intravenous contrast. So computed tomography is also very helpful in diagnosing Caroli's disease. If you scan a patient and you find what we have been describing, you can recommend for a CT just to make a confirmation diagnosis with a CT scan. So this is the transverse view. I'm just showing you a sonogram here of Caroli's disease. All these are images of Caroli's disease. Then Biloma is a localized collection of bile within the peritoneal cavity or within the liver, secondary to complication of biliary surgery. So when there is a surgery that has taken place, a biloma can occur due to surgery. So after surgery, we expect biloma to be there. I will quickly jump to ultrasound. We have an anechoic mass with prominent distal acoustic enhancement, a sharp, well-defined margin, and inoculation. Occasionally, internal echoes or debris and septations may be seen within a biloma. Then intrahepatic bilomas appear as cystic masses within the liver. Okay, so the differential diagnosis for that can be hematoma, it can be abscess, or both of which usually have more internal echoes and less pronounced distal acoustic enhancement compared with the Biloma. So accumulation of fluid in the gallbladder fossa is a common finding in the first week after cholecystectomy or after bile duct exploration, and it should not be mistaken for Biloma. These fluid collections are usually small and self-limiting and they resolve spontaneously. So the diagnosis of Biloma can be confirmed by hepatobiliary scintigraphy and percutaneous aspiration. Biloma can be treated by percutaneous catheter drainage. So we can see that one there. That's a Biloma longitudinal view of the right lobe of the liver, which shows a cystic mass contiguous with the liver with considerable distal acoustic enhancement. The mass is secondary to leakage of bile within the peritoneal cavity after biliary surgery. Then jaundice and pain. We have stone in the biliary passage, malignance, infection, infestation, Caroli disease. So these are the ones that you can see in jaundice. Thank you so much for listening, and sorry for taking too long for my presentation. I'll hand over to the Secretary General to take over or make some remarks, or if there are questions, then we'll be able to help each other answer questions, and then we'll see how we are going to move. Over to you, Madam Towera.
Thank you so much, Mr. Silavwe, for this packed presentation. Indeed, you realize that there's a